Assalamu alaikum. Good afternoon, everyone. Now, the task I have to address with you is related to diabetic emergencies. Now, in half an hour, to tackle three topics that relates to diabetic emergency, I think it will be difficult. So I think hypoglycemia is one of the topics and was addressed over the last 2 days extensively. So I'll leave it till the last, and if we have time, we'll discuss it when we present one case. But I'll focus on diabetic emergencies related to hyperglycemia, and then I'll make it a little bit interactive. You have to excuse me for this. It's meant to be meet the professor session, and it's meant to be a little bit more interactive. So I have those are my outlines and objectives that you will see clearly during the talk, and I have no financial conflict to disclose. Now, the first thing is when we talk about hyperglycemic emergencies is to define them. What do we mean by diabetic ketoacidosis and hyperosmolar syndrome? Are they the same entities? Are they different entities? Well, to start with, there are two of the most common acute complications of diabetes. This is no doubt about it. And when we talk about diabetic ketoacidosis, so we have diabetes, so we have hyperglycemia, since diabetes. Ketoacidosis, we have high ketone in the blood and the urine, and acidosis. So those three elements have to be kept together to call it diabetic ketoacidosis. Now, hyperosmolar hyperglycemia syndrome, basically you have hyperglycemia, which lead to hyperosmolarity. But the key element here is that because the serum osmolarity is high, there is some degree of altered mental status. So this is really, in succinct, really what we mean by both conditions. Traditionally, diabetic ketoacidosis was seen in type 1 diabetes and in patients who were less than 65 years of age. And the other part was seen in type 2 diabetes and more so in patients that were more than 65 years of age, mainly with comorbid conditions in nursing homes with multiple medical conditions. Surprisingly, mortality, if you think about it, is tenfold higher in the hyperosmolar hyperglycemic syndrome compared to diabetic ketoacidosis. And this is due to the coexistence of comorbid conditions that you see more frequently in the patient with hyperosmolar hyperglycemic syndrome. But again, both conditions can coexist at all ages. And the reason why they can coexist at all ages is when you look at the prevalence of diabetes, as been mentioned clearly in the first session, 68% are mainly type 2 diabetes. You have more chance to see those two conditions in type 2 diabetes as well as in type 1 diabetes. What is the cause and the pathogenesis? Traditionally, we used to say, well, diabetic ketoacidosis, because there is lack of insulin, there is tendency to have lipolysis and then high ketone formation, which leads to ketosis. And for hyperosmolar hyperglycemic syndrome, because it's mainly driven by increased stress, increased counter-regulatory hormones, you will see more hyperglycemia and you will not see glucose. But really, we know this is really simplistic, oversimplified classification, because both conditions, they share the same type of really etiology, cause, not etiology. Now, if you look at in both cases, there is either absolute, relative, or lack of insulin, along with increased counter-regulatory hormones such as glucagon, catecholamines, growth hormone. And if you start from the point that you have lack of insulin, the major point of insulin is it's an anabolic hormone, but at the same time, it prevents lipolysis. When there is lack of insulin, the increased lipolysis from fat cells, the increased flux of really free fatty acids, and those free fatty acids get to the liver where they go through a process called, well-known process called beta oxidation, which leads to the formation of two carbon moieties called acetyl coenzyme A. When there is lack of insulin, right, the acetyl coenzyme A, which is meant to go through Krebs cycle to generate ATP, is unable to go to that Krebs cycle. So what happens? They accumulate in the liver, in the mitochondria, and then more acetyl coenzyme moieties get together, and they form byproduct like the acetoacetate compound. Those subsequently are worked out in the liver to form what we know classically as ketone bodies. The three major types of ketone bodies are acetoacetate, acetone, which is volatile, and beta-hydroxybutyrate. On the other hand, you have increased counter-regulatory hormones, mainly glucagon, is 5 times more elevated than in normal cases. And that will lead to muscle release, breakdown of muscles, generation of amino acids. And what happened to the amino acids? They are shifted to make glucose. Hyperglycemia gets really to a higher level. Hyperglycemia leads to what? It leads to osmotic diuresis, it's a potent, very potent osmotic particle. And more diuresis, more dehydration, more impingement on the renal, so you have some renal impairment. But the end point here is in hyperosmolar state, the two major elements is you have hyperglycemia and dehydration, whereas in the diabetic ketoacidosis, it's dehydration again, along with acidosis. Those basically, and depending on the presence and the symptoms, you get to one stage more than the other. Now, what are the symptoms that really tells you you're dealing with one or another condition? Obviously, you have high glucose. So high glucose, what gives you? It gives you high osmotic load, right? The high osmotic load is going to drain fluids out of the intercellular space, get it into the intravascular space, and it's going to be excreted in the form of urine. So you're going to have polyuria, you're going to feel thirsty, and this is commonly seen in both conditions. Dyspnea, why do you get dyspnea in those cases? Anyone tell me why you get dyspnea? Right, so you have to, it's one way of compensating for the acid load that you have in the system. So your lungs are trying to get rid of the acid in the form of CO2, and that's why you get dyspnea. Abdominal pain, why we get abdominal pain? Nobody knows, actually, the mechanism, but we feel maybe it's due to increased prostaglandin and inflammation of the peritoneal wall that you get really abdominal pain. And it's not unusual for you to be called to the emergency room for someone who presented with an acute abdomen. More than one time when I used to do being on call, I've been called by surgeon because they wanted me to see pre-op patient because they felt that the patient had appendicitis or had other acute abdomen, whereas in fact it's due to the state of diabetic ketoacidosis. So I have to be quite aware of that, and it could be medico-legal case. Nausea and vomiting, we believe that ketones stimulate some center in the brainstem that induce vomiting and nausea, and that's why diabetic ketoacidosis patients, they tend to vomit a little bit at their own acute presentation. And the symptoms, because of the high level of ketones, because of that triggering mechanism of nausea, vomiting, and feeling unwell, they are discovered at a very early stage, less than 1 day or 2 days. Patient might have missed their insulin, or they have some insulin, decreased insulin reserve, they want an acute condition, they're going through surgery. Whereas in the hyperosmolar, hyperglycemic state, because most of the time they're elderly, they are in nursing homes, they have comorbid condition, they lack to recognize the thirst mechanism, they are neglected, left behind, they cannot communicate very well, and their presentation is discovered maybe later on after days, weeks, at the time when they present with very high hyperosmolarity and reaching above 300 milliosmol per kilogram. And that's when we discovered, that's why they are discovered late in the process rather than early in the process. But this is really all semantic. This is only to show you the close correlation between the level of serum osmolarity. And when we talk about osmolarity, what do we mean by osmolarity? Osmolarity is the concentration of particles that drain water towards them. That's osmosis, right? So they have the tendency to suck water out of the intercellular space toward them. The higher the osmolarity, the higher the change in mental status. You go from alert at the osmolarity of 320 to 330 being drowsy, 340 being stuporous, and comatose when you reach 360. Very early to reach that stage, but this is really a point to make in this. Examination, do you have any signs that differentiate? Both of them really will present almost the same. You have signs of dehydration, increased pulse rate, drop in blood pressure, decreased skin turgor, decreased urine output. Those are the common symptoms of really feeling dry. But there are signs unique to diabetic ketoacidosis, which is small breathing. Anyone tell me what's small breathing? It's a deep, fast breathing, normal breathing, because you want to take as much time to get rid of the CO2 that you have. Do you have apnea during the breathing in small breathing? You don't have apneic episode. That's what differentiates small breathing from Cheyne-Stokes breathing in CNS. CNS, when you see like patient breathing, and they stop, this is Cheyne-Stokes breathing. When they do, this is small breathing. Okay, this is really a point, really from clinical point that will help you really differentiate between the two. Another characteristic, fruity odor to breath. Why this is happening? Because of acetone, very good. Because acetone is one of the ketone acids that's volatile, and then they get it out, and then it smells like fruity smell or like the nail polish. And this could be, but again, both signs are not highly specific and not highly sensitive, but they are, when they are present, they are helpful. Whereas now lab testing is where you can make the differentiation between the two conditions. In both conditions, glucose is high, but in diabetic ketoacidosis, what's in the mild or more severe, it's really in the range of 250 to 500 to 800 in the diabetic ketoacidosis, rarely exceeding that level, whereas in the hyperosmolar state, it's usually above 800 or 600, reach 1,000. One case I had 1,200 milligram per deciliter. Arterial pH, usually in mild diabetic ketoacidosis, the pH is between 7.25 and 7.3. In severe, it's less than 0.7, 7.25. In hyperosmolar state, actually, it's normal, mildly decreased. Okay, this is an important point to keep in mind. Serum bicarbonate is normal in hyperosmolar state, whereas it's decreased in the diabetic ketoacidosis state. And urine and serum ketones, usually positive in the mild form of diabetic. We say usually because it might be negative, and I'll tell you why it might be negative. Whereas it's positive in the moderate to severe diabetic ketoacidosis, and usually negative in the hyperosmolar state. Now, you have to be careful because what ketones are measured when you measure the ketones in urine using nitrophosphatide testing? Are all of them measured? All ketones are measured in the... Okay, as I told you, one of the causes really due to lack of insulin that you get increase of free fatty acids get to the liver, right? You get beta oxidation that's increased, you have formation of acetyl coenzyme A, and you have formation of the ketone body. Acetoacetate by decarboxylation will give you acetone, which is volatile, and the other one by reduction will give you beta-hydroxybutyrate. Using the urine testing, only acetoacetate and beta-hydroxybutyrate are measured in the urine. Which is the most common ketones found in the blood is the beta-hydroxybutyrate. So in my form, whereas you might have beta-hydroxybutyrate in the blood, you test the urine, it could be negative because there's not enough acetoacetate and beta-hydroxybutyrate that been formed. And that you have to keep in mind that the best way to monitor your patient if they're acutely ill is to look at the serum rather than the urine. So in the case of really the mental stats, we said that really hyperosmolar usually drowsy and could be comatose. And anion gap is another element, okay? Which among the two, diabetic ketoacidosis or hyperosmolar state is associated with high anion gap acidosis? DKA, right. And what is anion gap? Well, it's a gap. It's a gap between cations, which are positively charged elements, and negatively charged elements, which are the anions. The most common cation in the blood is sodium, right? And the most common anion in the blood are chloride and bicarbonate. But there are some unmeasured anion, like the phosphate, sulfate, and some protein, which protein specifically is negatively charged, commonly found in the blood, is albumin, right? Those are not measured, right? So what you do, you take the cation, which is the sodium, right? You subtract the bicarb and then the negative one, the chloride, and you have the anion gap. And normally it's around 12. So I have this patient for you here just to make you wake up a little bit. I mean, it's been heavy lunch. So this patient is diabetic, presented with that. He's feeling unwell, and then his pH is 7.27. PCO2 is 23, bicarbonate is 9, sodium 131, chloride is 93. Does this patient have anion gap acidosis or not? I'll give you 1 minute. I'm taking it from my time. I think it's worth it. Who said yes? Raise hand. Who said no? Okay, that's good. Okay, so let's calculate this. So the anion gap is sodium 133. You subtract 9 plus 93, it's 29, right? The normal anion gap is 12. So you have high anion gap acidosis. There's no doubt about it. Now, just for the sake, put it on the side. Don't complicate. I'm putting it as an extra. Is there a way you can find out whether you have another mixed metabolic abnormality within that patient? Which one? pH? Yeah, pH can tell you, but it guides you, but you need something else with the pH. It's not, is what you would call, you can do what we call delta anion gap. What it means, delta anion gap, is you look at your own anion gap that you measured now, the 29, and you take away the normal expected anion gap, which is 12, right? So in this case, we got it to 17, right? What does it mean, 17? You have normal anion gap. The unmeasured anion are normally 12. In this case, 29. So effectively, you have 17 added hydrogen ions, acid moieties in the blood that being present in the blood, and those have to be buffered by the same amount of bicarbonate, right? So if you have 17 extra ions that been added in the form of hydrogen, you have to expect 17 bicarbonate moieties to go down, right? So if you take this and then you calculate your 17 plus what you measured was 9 is 26, and the normal bicarb is 24, so it's almost the same. So it's a pure metabolic acidosis. You know that what the drop in the bicarbonate is the expected drop in bicarbonate based on the amount of acid that was loaded in the system. I hope I'm not confusing you. Another element for those who are a little bit advanced, really. If you want to see if the primary event is primary or secondary, if it's primary, you look at the pH and the PCO2. If they go in the same direction, up or down, this is metabolic. So in this case, the pH was down, the bicarb was down, so it's a pure high anion metabolic acidosis. Just for the sake of really those going by levels. So the anion gap expected in DKA is more than 12 and less than 12 or normal in hyperosmolar hypoglycemic syndrome. Other lab findings could be relevant. Hyponatremia. You should expect some drop in sodium for different reasons. One is the salt, the expected salt loss that goes with the glucose in the urine. When the urine is excreted by the kidneys, it takes away salt with it. I mean, that's the exchange mechanism at the level of the kidneys. Or the patient has poor intake of salt, or because of the high osmolarity, what happened? The fluid from the intracellular is shifted out where the high osmolarity is present in the extracellular space, and you have dilutional hyponatremia. Other element that's really expected to be lost, there is significant loss of other electrolytes like sodium, potassium, phosphate, calcium, and magnesium. But please keep in mind, despite the deficit in potassium, total body potassium, what happens to the serum potassium? What level would you expect in patient? Can be normal, very good. Even can be high, not only normal. But that doesn't mean that really the patient has enough total body, it has a deficit. But because of the acidosis, what the acidosis does, it causes shift of the potassium from the intracellular space out to counteract for the movement of hydrogen inside the cells. And that's you have to keep in mind, because if you start, when you start fluid management and insulin, which is the key element in the management, right? The potassium shifts very fast back into the cells, and you might have significant hypokalemia. So if your potassium, you measure your potassium and you're starting treatment and the potassium is 3.3 or less, never give insulin first. Give the fluid first, correct the potassium, and then address the issue with insulin. Clear? Okay. Now the management, once you receive the patient, you have to know who should I maybe manage in the outpatient facility, or who should I admit to the ICU? And then if your patient is hemodynamically unstable, if the level of consciousness is below coma scale less than 12, if they have very high ketones, low pH, low bicarb, and coexisting medical condition, those obviously they need to be observed, right? In setting like ICU or special observation area. The management is clearly based on few conditions, few things. One, IV fluids, IV fluids, IV fluids. You can do with only IV fluids, even without insulin, right? That's what they need. They are really concentrated. They need blood. They need fluid. They need fluid because why? Because really of the high osmolarity state that they are in. Second, insulin, correction of electrolytes, and most important, the patient has a reason to present with diabetic ketoacidosis or hyperosmolar state. There are some precipitating causes that you have to identify. Otherwise, you correct from one side and it comes back from the other side. And the three most common, there are too many, but the three commonly that either the patient has undetected urinary tract infection, especially elderly, that nursing homes, or they have some acute gastroenteritis, or they have pneumonia and come with febrile illness, but anything can happen. Could be septic, could be anything that acutely flipped things back into perspective. But ever forget one thing, that the silent ischemia, especially in diabetic, could be coexistent and precipitated the event. And always look for that in the history, and then in testing, doing ECG, and do some testing to rule out this event. Isotonic fluids is the fluid type of fluid that they are advised to use. What does it mean, isotonic fluids? Sorry? Normal saline, you said? Isotonic, it goes by that definition. It means it has the same tonicity as a normal plasma, right? That's what means isotonic. You have to understand that the tools that you're using for managing your patient. If you don't know it well, you make mistakes. That's why I'm insisting on this. Now, I have this question for you. You have different solution, right? By the way, who is working within the setting of a hospital, not outpatient? Only few. So the other one really is just, but again, it's good to know. Really, it's always because you might be facing with this in the setting of really an outpatient facility. Someone come with high sugar. Lactated ringer, Hartmann solution, D5W, normal 0.9 normal saline. Okay? Are all the solution isotonic? Yes or no? Let's take it by lactated ringer, isotonic, raise of hand. Yes. Hartmann solution isotonic? Yes. D5W isotonic? No one. Normal saline isotonic? Yes. Okay. Well, effectively, all of them are isotonic. All have the same tonicity as a plasma. And I'm going to tell you what I mean by this. You know, you have different solutions that you're using. You have dextrose solution, water and sugar. You have crystalloid, like the lactate ringer or the saline, normal saline, and you have the plasma expander. And you have three compartments in the body. You have the intracellular compartment, you have the extracellular, which is divided into interstitial and intravascular. Right? You're with me so far? Okay. Now, dextrose solution has what? Has sugar and water. Sugar is osmotically very active. It has some osmotic effect. But it rapidly, once it gets into the system, is rapidly metabolized to be used as a source of energy. So once you get the fluid in, soon after, you're going to see that what you left almost free water. And free water, we call it free water because why? It can go freely between all compartments, intracellular, extracellular. Okay? Whereas the crystalloid, made of saline and other element, like added to it bicarbonate or lactate or so on, they cannot get through the membrane between the intracellular and the extracellular. Why? Because they need a pump and to be active. So the main phase is to stay in the extracellular compartment. Whereas the best one that stays in is the plasma expanders. So that's why normal saline is the best, or ringer lactase is the best solution to use in those cases. Now, if you give 1 liter of fluid, right, in the form of D5W, okay, what you expect to stay in the intravascular volume, only 80 milliliter of that 1 liter. The other is distributed in all compartments. If you give 1 liter of normal saline, 4-fold higher amount will stay in the extracellular compartment, okay, 250 milliliter. Whereas if you give 1 liter of plasma expanders, the whole liter stays in the plasma expander. That's why when you have someone hypotensive, lost blood, and so on, we give them fresh frozen, we give them blood. So the best solution are isotonic solution, are normal saline or ringer lactate. I don't know how I'm doing with time, but so far I didn't get this time. I'm okay? Okay. Now, the first thing, you have to bolus your patient because they are too dry. You give them 1 to 2 liters of either normal saline or ringer lactate. Then, after giving the bolus, you reassess the volume status. Okay. I have 5 minutes. Okay, so I told you, well, barely we'll go through this. And then you assess the volume state. Patient still volume depleted, you continue bolusing until really the condition of the volume status is corrected. Mild volume depletion, you got to some extent. Now you check the serum sodium. If the serum sodium is still high, it means they still need full normal saline. They need half normal saline because they need to be diluted, more free water in it. If they are sodium low or normal, then you can keep with the normal saline. And then keep in mind, not acutely, but once you have swift maintenance, fluid maintenance, sodium rise should not exceed 0.5 milligram per liter per hour. I'll go a little. Insulin basically is the mainstay treatment. There are different protocols, but the easiest one to remember, you give a bolus of 0.1 unit per kilogram, and then maintenance, you give them 0.1 unit per kilogram per hour. You adjust that based on the weight rather than tickets, and your target a rise in blood sugar not more than 50 to 70 milligram because of the risk of really inducing cerebral edema. And once the serum glucose is less than 250, you add dextrose to the IV solution to give them a source of carbohydrate to prevent hypoglycemia and to prevent cerebral edema. Reassess every 1 to 2 hours, electrolytes every 2 to 4 hours. And when do you decide that really things come back to normal? Once the volume status has normalized, mental status has normalized, anion gap is less than 12, bicarbonate more than 18, and pH has normalized. Then you switch to insulin, but always keep in mind, keep 1 to 2 hours gap. Maintain the insulin infusion for 2 hours after you give the sub-Q insulin, because it takes time for sub-Q insulin to get into effect, and then stop the infusion. Euglycemic diabetic ketoacidosis, briefly, has been lately described as a condition where you have ketosis, you have acidosis, but the glucose is not really high, it's less than 250. We have seen this now with the introduction of SGLT2 inhibitor as anti-glycemic condition, medication, or lately we know that this condition actually exists because there is some degree of insulin within the system, but the patient, the amount of insulin is very minimal, and the patient goes through an acute event, either surgery or sepsis or infection or misdiagnosis. They are ladder type, as mentioned, and then that's why they present with that minimal glycemia, mainly ketose formation. Having said this, I'll skip this, and hypoglycemia, to mention that the main management of hypoglycemia is, if patients is minimal hypoglycemia, is to use the rule of 15. You give them 15 grams of carbohydrates, you wait 15 minutes, reassess the blood sugar, and then if still on the low side, give them 15 grams of glucose until the glucose comes back to normal. Now, if obviously more than that and obtunded, you could use a glucagon or use dextrose IV or in the form of D50 or D25 or D10. But I want to take you to that case because really lack of time. Let me give you this. This is a case, 65-year, and we'll finish. 65-year-old male, non-diabetic for 10 years. He's been on glimepiride, 4 milligram daily, and metformin 1 gram daily. He was found obtunded and mentally confused. He's brought to the emergency room. Vital signs are adequate. He's afebrile. Blood sugar is 2.2, obviously on the low side. Initial management, 1, to start IV glucose 10% at 100 ml per hour, to give IV bolus 25% D5W, or to give somatostatin 75 milligram IV or sub-Q. Who goes for 1? D5, give them D5, and then to give the sugar high, so at least to prevent that hypoglycemia. No one? Okay. Who would give IV bolus? Okay, the majority. Who would give somatostatin 75 milligram? No one? Okay. What do you think the right answer is? Actually, the right answer is 3. You have to actually not D5. Actually, you make things worse by giving them D5. Why is that? Because sulfonylurea, what is the mechanism of sulfonylurea? It works through glucose-mediated insulin secretion, right? And they are on board. They have long half-life. They're gonna stay. You give them D5W, yeah, they're gonna become again hypoglycemic. You're gonna have more insulin secreted, bring them down again to low blood sugar. So you have to block beta cell secretion, give them somatostatin, and then reassess them. If they need, then you can give them glucose. With this, I stop at this level, and thank you very much for your attention.